Hello, everyone, and welcome to our webinar. I'm going to give it another few seconds to make sure everyone who wants to join us has joined us, and then we will begin in just a few minutes. Okay, well, I'd like to go ahead and get us started. Welcome everyone to this webinar on the connection between intimate partner violence and brain injury. This will be a training for you all who are social workers, medical providers, and of course, the community. I'd like to introduce myself. My name is Dorothy Kozlowski, and excuse me, and I will be joined by Dr. Sonya Crabtree-Nelson. And if you go to the next slide, Sonya. Okay. A little bit about us and why you'll be hearing from us today. I am a Vincent DePaul Professor of Neuroscience at DePaul University in Chicago. I am someone who has a background in research on traumatic brain injury. And a number of years ago, the connection between brain injury and domestic violence was brought to my attention. And it was really an eye-opening moment. And I decided to connect with Sonya and along with a lot of other individuals. And we founded, and I'm now directing, the Illinois Coalition to Address Intimate Partner Violence-Induced Brain Injury. And now I will ask Sonya to introduce herself as well.
Hi, everyone. I'm Sonya Crabtree-Nelson. I'm an associate professor of social work at DePaul University in Chicago, and also the co-founder of the Illinois Coalition. And prior to my time in academia, I was a practicing social worker working in the field of domestic violence as well. So this has been an issue that I've been very passionate about for quite a few decades at this point. And we're very excited to have you all joining us.
And before we go forward, just if you have any questions for us, there will be a Q&A at the end. So please go ahead and submit your questions either in the Q&A or in the chat. They will both be monitored and your questions will be considered at the end.
Absolutely. We have to say that we do not have any disclosures to let you know about. So, okay, starting us off, I do want us to center on the issue of domestic violence or intimate partner violence. I'll probably be using the two of those somewhat interchangeably this afternoon. But first, I wanted us to think just a moment about the difference between toxicity and abuse in a relationship. And this is something I get asked a lot of times during different trainings. I do different classes I lead. Folks will give me all sorts of examples and be like, well, would you say that's abusive or would you say that's just bad or toxic? And I've heard this from clients as well who often say, well, I don't know that I'd call it abuse. It's just probably unhealthy. So while the two of those have many overlapping qualities, of course, what we're centering on today is those relationships that are actually abusive. And in that, of course, the abuse is more intentional, often creating a potentially harmful environment, often utilizing tactics to isolate or intimidate their partner. Usually the person perpetrating this is aware that they are committing harmful behavior. And we're going to talk about the different types of abuse that it occurs. But I do want to highlight the definition that we'll be going off of today for IPV, which is a pattern of coercive behaviors to control one's partner through physical abuse, the threat of physical abuse, repeated psychological abuse, sexual assault, progressive social isolation, deprivation, intimidation, or economic coercion. And I'm guessing many of you have heard of the pattern of abuse. So much research has been done on this over the, quite a few decades now, really looking at abusive relationships and how there is sort of this almost cyclical pattern where there is this tension building phase, things are getting more stressful. The victim might actually be trying to reduce tension, will comply, will be saying they're trying to do everything right. And then some abusive incident will occur that can be verbal, emotional, physical, and it's going to include, anger outbursts, intimidation, threats. And then usually right after that, especially at the beginning, there's this reconciliation. The abusive partner is apologizing, might show remorse, might beg for forgiveness, might shower their partner with all sorts of praise, flowers, gifts, things like that, promising it will never happen again. And then, folks say then there's sort of a calm that occurs. Now, pretty much every survivor I've talked with over the years had said, well, you all might call it calm. I wouldn't classify this as calm because I'm walking on eggshells, basically. Like I always know something else is coming. I just don't know when. And so we also know that this pattern will usually become a quicker and quicker pattern over time. So in the very beginning of a relationship, it could be weeks, months before a next incident occurs. And often over time, that becomes quicker and quicker so that many survivors will talk about numerous incidents within the same day. So thinking about different signs of abuse that you may all see. And there's a lot of them, right? Depending on what kind of abuse we're talking about. And for many survivors, they're experiencing all of this, right? They're experiencing physical, emotional, verbal, sexual, financial abuse. And for some, they're experiencing mainly one. And those are the folks that I think in my practice will come to me saying, I don't know if this is really abuse, but I feel like finally I should talk to someone. So it's so great that you all are coming and listening and learning more today too. So physical, right? You might see folks coming in with layered and baggy clothes, even when it's really warm outside. You might see different injuries that folks may even excuse away as happening in different ways other than an abusive incident. May talk about pain in different areas that just doesn't necessarily make sense to you. And may have just shifts or change in how they're acting, speaking, their mannerisms. In emotional abuse, lots of times, and here we're talking about things that the person is being accused of, but so often we will see the survivor who is feeling ashamed, who is feeling that they're losing their minds, they feel crazy. They think that they must be stupid because these are all the things that they're being told by their abusive partner. Lots of times they might be accused of all sorts of things that are not happening, right? That they're flirting with other people, that they're trying to get the attention of someone else, that they're using their family and friends against their partner when in essence, none of that is actually happening. When we go to sexual abuse, lots of times it will consist of, the perpetrator trying to get the partner to dress in certain ways. And it might be initially that they want them to dress, more sexy for them. But then usually it quickly ends up not wanting them to show off any part of themselves because they're certain that they're just trying to get other people's attention. It can be, demanding sex even when the victim does not feel like it. It can be forcing sex. And even in today's day and age, I will have, survivors come to me and say like, well, since we're married or since we're in a committed relationship, I feel like I have to. But once again, of course, they do not have to. They are being manipulated or forced in many cases. Finances, we often see this being a part of lots of abusive relationships, right? It can be everything from sabotaging the person's employment by, you know, calling too often to their place of employment, by calling them when they're at work, by doing things that have them missing work, controlling the money, ensuring that the survivor, you know, only gets maybe an allowance of some kind, all sorts of things that we've heard. Now I'm going to turn it over to Dorothy to talk a little bit more specifically about brain injury. So this is going to be that part connected to physical abuse. And I will preface it by saying that I do think still many survivors I've talked with, when they've been strangled or choked, do not consider that physical abuse. And I think after you listen to Dorothy, you are going to have a very different opinion of that.
Thank you, Sonya. So the idea that brain injury could be something that's happening in survivors of intimate partner violence was really not on a lot of people's radar. About 2015 or so, there was a Huffington Post article, bringing it to light. And it's not like people didn't think about it or didn't know about it before that, but it just really wasn't at the top of people's minds, especially those who were in the brain injury field, like myself. And then when I met Sonya, I learned that it really wasn't on the radar of individuals who worked with survivors. But after you think about the descriptions of what Sonya just provided of the physical abuse that individuals who are in violent relationships experience, a light bulb, an aha moment goes off that, well, of course, if someone is being hit in the head, if they're being choked, etc., that is not without consequence, that can cause different types of brain injury. So, and that there are resulting symptoms from that brain injury that a lot of times survivors and those who work with them can just kind of sweep away and say that, well, that's just who they are, that's just the kind of person they are, etc. So when we talk about brain injury in survivors, we think about it coming from two different places. We think about head trauma. So this is basically if someone is hit in the face, the typical black eye that you may think of when you think of someone who is in an abusive relationship. But if anyone is hit in the head, or if they are shaken violently, if they are abused in such a way that they fall down the stairs and hit their head, if their head hits another object, etc. These are all ways in which your brain can suffer what's called a traumatic brain injury. We think of concussion in sports as being hit in the head. Well, those kinds of injuries can also happen in a survivor of intimate partner violence. How many does this impact? Well, we don't know. The numbers that are out there are really underreported because this is still not something that is well documented. But we do know that in those who are in abusive relationships, it can happen more than once, right? Someone who is in a violent relationship usually experiences multiple episodes, sometimes very close to one another, that can actually make things a lot worse for brain injury. Now, another way that brain injury can occur in survivors is through choking. So any type of an event that results in the lack of or the decrease in the flow of blood to the brain can result in a brain injury. So this is, obviously someone being strangled or someone, putting a lot of pressure on the chest so that the person is not getting the oxygen and flow to their brains. That too can result in brain injury. It's a special type of brain injury called a hypoxic ischemic brain damage, but it too results in symptoms. And with choking, you all know better than I do, those of you who work with survivors, that it's a really high indicator of lethality. And with a head injury, like a head trauma, you might see a black eye or some other forms of signs of injury with choking, there's not necessarily always an external sign of the injury. But with both brain injury, both due to head trauma or due to strangulation and choking, symptoms are very, very similar. So there are sort of more more physical symptoms, there's cognitive symptoms, there's emotional symptoms. But the symptoms can be things like headache or fatigue or brain fog or dizziness, visual changes, ringing in their ears. Individuals with multiple brain injuries can develop a seizure disorder. And we'll talk a little bit more in a few minutes about what other types of symptoms can occur following a violent episode. And we'll get into those details in a minute. So, what do we know about the statistics? Well, like I said, there's not enough data out there to say exactly X amount of people experience brain injury who also experience IPV. We're working on that, but we don't have those exact numbers yet. We do know that up to 90%, 92% of survivors do receive some sort of hits to the face or head during violent episodes. And 68% of women report strangulation. A lot of our data does come more from women, but we do recognize that men experience IPV and that also the LGBTQ TI plus community does as well. A staggering statistic is that there is an estimate that traumatic brain injury in the context of domestic violence, that it happens 11 to 12 times more than just traumatic brain injury in the general public that you would get from, recreational accidents or occupational events. So, a lot of efforts and time has been spent to bring attention to traumatic brain injury in the context of sports, which is wonderful and important. But thinking about this number, that there's probably so many more survivors who are impacted by brain injury is staggering and gives us pause. And we're really grateful to those of you coming to learn about this, and of course to CLF for bringing this to your attention as well. So if you do this math and you think about the number of women who experience IPV, there may be approximately 27 million women who are likely to be showing some symptoms of traumatic brain injury. And the problem is that the majority of individuals who are showing these symptoms aren't linking it back to their violent episode. They just think it's who they are or a problem that they have. They don't necessarily see that it's coming from the violence they're experiencing. And because of that, they don't necessarily seek care. Okay. So I brought up the idea of a repeat concussion. Obviously, a lot of us have heard that getting multiple hits to the head in the context of sports is not a great thing. The idea of a repeat concussion is that you can have multiple hits to the head over a period of time. And when that happens, it can prevent your brain from healing. Why? Because you're already injuring vulnerable cells in your brain that are responsible for communicating. And this has been shown to lead to much longer term deficits. So long-term consequences with your memory, with your emotions, with some physical symptoms that you're experiencing. And there have been links, at least in individuals who were professional athletes or the military, that there is a link to an increased risk of neurodegenerative diseases, things like Alzheimer's disease, Lou Gehrig's disease, Parkinson's disease, and CTE. And we don't have data yet, conclusive data, to show that survivors with multiple hits to the head are also having these increased risks, but that data is being collected as we speak. So why should we care about this intersection? Why is it that we should pay attention to brain injury in the context of intimate partner violence? Well, like I said, most survivors are not aware that their symptoms are due to a brain injury, but their symptoms can affect a lot of their ability to get the right type of care. So it's going to affect their initial interview by police or paramedics. So if police or paramedics come to a scene where domestic violence, intimate partner violence is happening, they may encounter a survivor who doesn't want to speak to them, or when you ask them questions, they're like, I don't know what happened. I don't remember what happened. And they may think that this person is being difficult when in fact, they may just be overstimulated by all the lights and all the sounds. And they may have experienced a brain injury that affected their memory. They don't remember what just happened to them. They're not just being difficult or trying to protect the perpetrator. And then, those of you who work with survivors, you know that in order to access services, there's a lot of instructions to follow, a lot of forms to fill out, a lot of appointments to follow through with. That's really difficult to do if you are suffering from a brain injury. And then lastly, decision-making is usually affected following a brain injury. And so if you're trying to make decisions about your family, about your abuser, that's going to be impacted by the brain injury itself as well. So like I said, I was going to talk to you all a little bit more about the different kinds of symptomatology and what that might look like in the individuals that you may be working with as providing services to survivors, or if you're a survivor yourself. So some of the symptomatology after a brain injury is that a survivor with a brain injury could, struggle with becoming easily frustrated, have inappropriate or aggressive behavior, or feeling angry, impulsive moods and fluctuating moods. And we know that emotional symptoms are already there or can be there because of the trauma that they're experiencing, but those can be exacerbated. So how is that going to impact their services in their lives? These individuals, if you're trying to work with them, may look like they're non-compliant, say things or do things without thinking, maybe not getting along well with others or challenging others. They're not following directions, talking about how they're feeling hopeless or withdrawn, and they may even be talking about harming themselves or others. Following brain injury, there could be cognitive symptoms. Survivors can struggle with their memory, having difficulty thinking through their thoughts or finding their words or understanding what is being said to them. They may have a hard time getting started on a task or following through with a task because they're having trouble maintaining their attention. They may not be able to problem solve well and making those decisions around judgment calls or doing risky behaviors. So how might this look like when you're interacting with the survivor? Someone who is easily distracted, having difficulty concentrating, feeling confused, forgetful, unfocused, scatterbrained, not seeming like they're interested or engaged with the help you're trying to give them, missing deadlines, missing appointments. You're like, oh, if they could only finish this form, they could get the services they need, but they may not be able to do so because they can lose their train of thought and not follow along with the instructions that they're being given. And then they also may have physical symptoms. So these are symptoms like sensitivity to light and sound is a big one. Someone with a brain injury can have problems with their vision, blurry vision, double vision, having trouble with sleep, having either sleeping too much, not sleeping enough. Like I mentioned before, seizures, headaches, dizziness, poor balance, fatigue. And with strangulation, you also may have trouble with swallowing and neck pain. So how might this impact your interactions with them? They may just feel like they're in a fog or explain to you that they feel like they're in a fog. They may express pain, discomfort, not being comfortable in the seat when they're trying to sit with you. Talking about difficulty falling asleep, staying asleep, waking up. You may notice that they're having trouble focusing or, on the paperwork you're trying to get them to finish or hearing exactly what you're saying. They might be bothered by the fluorescent lighting in the room or, be distracted by noise that they're hearing. They also may be clumsy, tripping or bumping into furniture and just having no energy and not really, if you're in a shelter situation, just being tired and not wanting to be involved in the normal activities that were occurring. So a lot of times people ask us, in the context of brain injury and these symptoms, well, aren't these people, aren't survivors just experiencing PTSD? Sure, they probably are. And do we need to separate out what is a symptom of PTSD and what is a symptom of brain injury? And really, what we like to say is that, well, PTSD is probably something that has been occurring throughout their trauma, and a lot of them, these symptoms do overlap with the symptoms of a brain injury. But if these symptoms are new after a violent episode, or if they've gotten worse after a violent episode, most likely it's probably a symptom of the brain injury and not previous symptoms of PTSD. But really, in reality, there are many symptoms that overlap. So the fatigue, sleep problems, problems with memory and attention, and other emotional issues and cognitive issues, there's definite overlap between the two. And really, when it comes to treating someone with traumatic brain injury or treating someone with post-traumatic stress, really what you're treating is the symptoms. You're not necessarily treating underlying disease. So the good thing is that there are treatments for all of these symptoms. There's medication, there's therapy, variety of different types of therapy: physical, occupational, speech, cognitive, psychological, et cetera. But the problem becomes is that it becomes very individualized. There's not a cookie cutter set of therapeutics that individuals are given with a brain injury. It's extremely individualized. So if you are someone with a brain injury and you are a survivor, the access to brain injury services aren't easy. It usually starts with either a trip to the ER or to your primary care provider. And then, the symptoms are sort of teased out, and you're trying to decide, what type of therapy would be best. And like I mentioned, it's quite individualized. And if you go to a brain injury clinic, for example, the focus typically is on sports concussion, which the approach to that is really very, very different than trying to rehabilitate someone. The focus is on rehabilitating someone to go back to play a sport, as opposed to working through a very challenging set of circumstances that someone with intimate partner violence is trying to navigate. And then also, the brain injury itself makes it very challenging for an individual to make appointments, find care, follow up, get to these appointments, the transportation, the childcare, the navigation, et cetera. So it's definitely not easy.
Okay. Now we're going to go back to talking a little bit about, helping someone who you're working with to really begin thinking about whether this fits for them. Because if you're like me, I've had many folks say, well, I'm not sure this is abusive. I know you've talked about it, but I'm not sure. And many of you are probably aware that there's all these tools online. The power and control wheel is a big tool we use in the field of domestic violence, to talk with survivors about the different types of tactics that are used in their different parts of the abuse. And so it fits a lot with some of the things we talked about earlier with emotional abuse, and verbal abuse. So lots of times I've found when I talk with a survivor, show her even, one of these wheels and start saying, if anything, let me know if any of this sounds familiar. And so, 9 times out of 10, the person says to me like, oh my gosh, like this could have been written about my abusive partner. All the different things. And so just know that, these, you could just Google it if you haven't already. And there's so many different power and control wheels. I just wanted to even put up one, they're all different ones specific to different communities as well. So even power and control in queer relationships. And you can basically find a wheel to fit different groups that you're working with. And it can be a helpful tool to have on hand. I do want to show a brief, I think it's about a 4-minute clip for a survivor's story, and really talking about her story from the beginning and her abuse to the point of wanting to give back and help others. And
my life before Raphael House was crazy in a sense. I was in an abusive relationship that I, at that time, did not know was abusive. There was a lot of yelling, a lot of arguing, a lot of fighting. It was scary. And when it became physical was when I left, because that's what I knew was abuse. I was terrified of losing my children. I was terrified of a new environment. I had never been on my own. It was a scary, terrifying, and at that point, lonely experience before I got to walk through the doors of RH. When I first came to shelter, I was scared. I heard all these horrible things about shelter. I had no idea that I would walk into somewhere that was so welcoming to me and my children, not even knowing the whole story, just wanting to be there and wanting to help. They made sure that I knew, that if something did come up, I had somebody on my side, and I had never had that before. So it was extremely important and powerful in that moment, and helped me to be able to see that there was life outside of my abuse. And if I would have never had that experience or chance, I can't say I'd be where I was today, because it showed me a light at the end of the tunnel, that there was a chance for life after abuse, that I can do this on my own and build my own support circle. And that was important. That stayed with me. It's still with me. I had a goal of working at the Raphael House. Like when I lived here, when I stayed here, I knew I wanted a job like this. I wanted to work here. I wanted to be able to give to people, or help give to people, what was given to me. I wanted to be able to do that in life. And I wanted that for a long time. I think my last day here was in 2010. And I started working here in 2019. I am a domestic violence recovery mentor. I get to walk beside people who have been through domestic violence and are seeking recovery. We get to help our survivors and participants build a support system so that they can be successful out in the community on their own. So they don't have to lean on drugs. They don't have to lean on their abuser. That we get to help them find another way of life. What I love about my job is I get to show up to work as me, with everything I've been through, all my flaws, all my great things, I get to show up as me. My criminal background, I needed that for this job. I get to show up as me. I get to share that story. I get to just be authentic, and that helps the next person. I get to be a person that they can talk to, that they know has already been through that or something like it. And that makes a world of difference, because talking to someone that has no clue what you've been through is a lot harder to grasp their understanding and know that you're safe. I have custody of my children. They stay with me. I have my own home. I have my own, I'm able to buy food. I'm able to pay bills. I actually like to pay bills because I'm able to do all these things. I am in recovery going on 5 years. I'll have 5 years, October 26th. And I'm able to walk alongside people that were in this position where I was at when I started, when I had no hope and didn't know that I could do these things on my own. So my life is amazing.
I love to show that because I do think that so often society especially, can get stuck thinking about the fact that, oh, folks never get out of those situations. It's, not very viable. What we're doing isn't always that helpful. And I think that it so is, right? It so is helpful. And it's so important for people to have folks who believe them, who listen to them, and are able to help them get to that next step. Sorry about that. Forgot to turn my video back. So now one of the things I like to touch on as well is sort of what I'm asked all the time. So, what causes IPV? And of course, when the movement started back in the 70s, domestic violence movement, it was really focused on patriarchy. That patriarchy was the reason for domestic violence. And so hence we needed to, shape our services, shape our legal response really based on that. But we've learned a lot in the time since then. And we also know a lot more about colonialism. We know about systematic oppression, and we're learning more and more about the way that people sort of inherit generational trauma from past experiences. So what we know now is that communities that have been systematically oppressed, largely in our country by white settlers, they're passing along that generational trauma that is now also contributing to domestic violence. And, could join one of my classes and we talk a great deal about this, but I just wanted to ensure that I was emphasizing that it's more than patriarchy. And many of my students would say it has, a lot to do with, different aspects of our society, our, reliance on putting basically power and privilege above all else. So, what misconceptions do you believe society has about IPV? And I think they are many, right? When I, go to a party and folks ask what you do, I'm a professor, and then what do I research? And as soon as I start talking about IPV, some folks just quietly walk away. And others, of course, start saying, well, that has to be hard, and then proceed to talk about a lot of misconceptions that are held out there. And, some of them are, well, the folks must really get something out of being abused as well, or they would just leave, right? Some folks say that, well, there are certain groups of people that just lend themselves to being abused more. Lots of misconceptions. So we're going to talk a little bit here. We do know, right, about 1 in 3 women, about 1 in 4 men have been victims of some form of physical violence by an intimate partner in their lifetime. And those are I throw that number around all the time, and it's startling, right? 1 in 3, 1 in 4. So what I say to folks that I talk with all the time in this, you don't have to be working in the field of domestic violence to know that you'll be working with folks who have been impacted from IPV. We also know 54% of transgender and gender expansive folks have experienced some form of intimate partner violence, so over half. And there's a lot of diversity, right? We know that IPV can affect everyone, and yet our identity can shape our experiences, right? If I am poor and don't have access to good health care, I don't have access to therapy, I don't have access to different help, it's going to be much harder for me to get the support I need. Depending on my immigration status, that's going to affect whether I feel comfortable even reaching out, whether I know what the laws even are in the country. Sexual orientation, once again, a lot of misconceptions, whether a woman can abuse another woman, whether a man can abuse his male partner. And of course, yes, right? We know that's absolutely true. Disability can factor in abusive situations, so that someone who's also caring for someone who has an ability and is their partner, it can make that situation very challenging and murky if the person who has some disabilities is also relying on their partner. And race. Early on, of course, in the movement, we like to talk about the fact that domestic violence sees no color, right? Sees no skin tone. And yes, that is true, but we also know that our society is generally a pretty racist society. So how folks are treated based on their race, as well as all these other things we talked about, is going to impact the type of help that they are able to receive and how others view them. And some of that is who's seen as a victim. There are quite a few folks in the African-American community who have reached out and stated, you know, as a Black woman, I'm not the perfect victim. That's the, you know, sort of quiet, meeker white woman who folks want to rush in and take care of. But if I'm here and I am arguing back or fighting back, I'm perhaps seen as someone who was more deserving of the abuse. Society has a very skewed opinion on who sort of fits that victim status. And all this, of course, can affect people's access to support and resources. Our healthcare system, for one, is very challenging for many people in our country. If you don't have good insurance, it's harder to even think about following up. When Dorothy mentioned that many folks don't seek help for injuries related to domestic violence, some of that is the stigma, and some of that is also just their access, their ability to pay for that type of service. And so I touched on in the last slide just briefly this sort of resistive or reactive violence. And there's a lot of confusion still, I think, in our society about a victim who is fighting back. I often give an example to my classes, case example, and it shows someone who is being abused physically, initiated by one partner. And when the person sort of responds back and shoves them, lots of my students will initially state, oh, well, it seems like it could be mutually abusive. And I want to put out there that someone trying to fight back or resist the violence is not the abusive party, right? They're not being coerced in that way that we talked about at the beginning of our presentation. And here, this little quote, right? A victim's use of violence ends when the relationship ends or the abuser stops abusing, but the abuser will continue to abuse their victim indefinitely and often more intensely as they feel a loss of control over their victim, either within the relationship or when it ends. I want to link to a safety planning tool. In the field of DV, we always talk about the importance of making a safety plan. So if someone discloses their abuse to you in any kind of professional setting, lots of times we'll say, you know, to listen to them, to hear them, to validate their experience, and also begin safety planning. Early on, I thought this meant like some magical safety plan that everyone uses, and I quickly found out that there are numerous ways to do a safety plan. And now, of course, that there are numerous online tools to help. And you'll have all of these links, but I just wanted to quick show this to you. That, of course, this allows you to even walk through and help plan with the person in front of you. You don't even need to fill in information, although it gives you the opportunity to fill it in, to print it out, if it is safe for the person you're working with to take it with them, or if you want to put it in their file. But it just walks through a lot of things that they can answer or not, and helps you to think about what also could be helpful to talk through, because each person's unique, right? Each person is different in what could be helpful, but it has you and them thinking about, you know, who are supports, thinking about what kind of documents they maybe should gather and have in a safe place that if they are needing to flee quickly, they could take those documents with them. You know, really thinking through all the steps. So once again, just a helpful tool. And this is one of the ones I like that's online. So just a brief case study. I love a good case study to begin thinking about how you might go about helping them. And so feel free to read it. I will also read it out loud. Sarah is a professional working woman with a successful career in interior design. She met her partner, Mark, in college, and they have been together for over a decade. They have 2 young children together. Over the past few years, Sarah has noticed a pattern of escalating verbal and emotional abuse from Mark. It started with subtle criticisms and controlling behaviors, but has since escalated to threats and physical violence. Sarah has tried to keep the peace for the sake of their children, but the situation has become unbearable. The abuse has taken a toll on Sarah's mental and emotional well-being. She experiences anxiety and depression, struggles to concentrate at work, and has isolated herself from friends and family out of shame and fear. Last night, Mark put his hands around Sarah's throat and choked her until she passed out. She believes her children saw this. Her head has been foggy all day today, and she just doesn't feel right. Sarah plans to call the hotline number she looked up a few weeks ago. Sarah's children have also been affected, witnessing their parents' fights and experiencing the tension in the household. So I just want you to begin thinking, how might you begin that safety planning with Sarah? If this was something that was told to you in your setting, what might your first instincts be for how to help her? Thinking about her situation, thinking about the kids, thinking about also the choking that she told you about that just occurred. So something I like to talk about when I'm talking with social workers in training at DePaul, and I know that many of them will not be going into the field of domestic violence, but still, of course, like we said, we'll be working with folks who are survivors. And the research shows us that when survivors are asked, what's the thing that was most helpful to you, that really stood out? Usually the first thing they say is, when I talk to, X person, they listened to me. And I could tell that they just believed me without judgment. They validated my experience and my feelings. And that we can do that type of validation within a couple minutes, right? So oftentimes, we encourage our social workers not to instantly rush into okay, here's a hotline number you could call. Because what they're looking is, they're reading us, right? Do you believe me? Is my story worth it to take in and know and help me with, as opposed to just pushing me to the next person down the road? And what we know is that if I'm working at a mental health agency, someone discloses this and I say, well, here's a number you could call. And then I go back to whatever we were talking about. Odds are they're not going to call the hotline number, right? They were hoping to have a little more connection from me. So listening, right? And knowing those warning signs, thinking about, has this been escalating, right? Is this something that I should be developing a brief safety plan, knowing if they're talking about things escalating, is there concern for them to go back home today? So having that safe space to listen, to ask some more follow-up questions. And when I talk about intentional language, I usually really try to use the language that the survivor is sharing with me. So if they say to me, Sonya, I don't know, my partner is doing things that just don't feel right. I might be making it all up in my head. I'm not gonna, within the next little bit say, well, it sounds like you might be being abused, because instantly the person's, oh, no. Don't worry about it. We don't have to talk about this. It's not abuse. So I use the language that they're sharing. In the same way, when Dorothy was talking about traumatic brain injury and strangulation, lots of times we know that survivors won't use those, right? They'll say, well, I got hit upside the head, or, put his hands around my neck. So I will try to use that same language as they are. And there are numerous tools, which Dorothy's going to talk about in a little bit here, but there are different tools to use to determine if a brain injury may have occurred. And once again, those tools are using a more survivor-friendly language. If you have time in your space and your setting allows for it, begin to think about a safety plan, or at least share the online tools with the survivor as something that they could check out later if there's not time in your setting. And if you do have time to do that, just like Dorothy said, especially if someone may have had a brain injury of some kind, remember to be very clear, specific, repeat instructions. Know local resources that you can connect them to. And make sure that they know once they're leaving your setting that there are different support services for them. And if it's possible for them to contact you again, of course, now they've disclosed it to you. If you're the first person they've disclosed to you, they may want to come back and talk with you again about it if that's possible. And then just consulting with others. Lots of times it really does take a village to help folks. And so the bigger our network is, the more helpful that can be.
Okay, so thinking more about resources, and not just resources focused on working with survivors, but resources focused on working with survivors with brain injury. And during the introduction, Sonya and I introduced ourselves as being the co-founders of this coalition. So we are both in Illinois. And in Illinois, we have created this coalition to help navigate what do we do with this population that has brain injury induced by intimate partner violence. And so the link to our website is here. I'm not going to go into the website, but really what our goals are to educate, which is what we are doing with you all today. We do conduct research on this because, as I mentioned, there's just not a lot of data out there about this intersection. We're working to enhance services for those survivors who do specifically come to us with brain injury and come to support services in Illinois with brain injury. And then, of course, advocacy. And we work a lot in partnership with the Ohio Domestic Violence Network, who you also have the link to here. They really have been the national leaders around this issue because they have it's a statewide organization around domestic violence, but they have specifically this Center on Partner-Inflicted Brain Injury. And the next slide will show you some of the resources that they have for those of you who work with survivors. So you can kind of get an overview of this connection between brain injury and intimate partner violence in this free pamphlet. And this is specifically for individuals who are working with survivors. And then earlier we were talking about, how to, we're not asking anyone to diagnose brain injury when you're working with survivor, but just keep brain injury in mind. Actually, I'm going to go back. Yeah, thanks. But keep brain injury in mind that some of the symptoms you're seeing are probably potentially due to brain injury. And so how might you accommodate this person you're working with? And so the materials that you see here, this checklist here, this head injury accommodations, has a long list of things that you can do to help ensure that you are accommodating for and keeping in mind brain injury as you work with the survivor. So the next slide will also provide you with some resources for the survivors themselves. So there are these head injury education cards in both English and in Spanish that you can access, either download, or we can provide you with physical copies of. This can be, we have them here in Illinois and in shelters and in other service organizations. We have them in our domestic violence courtrooms. These can just be ways that someone who is a survivor might start thinking about, well, yeah, my head has been hurt. Do I have these things? And it might start the conversation with the survivor that they might be experiencing brain injury. And there are a lot of other great resources for survivors themselves who think they might have brain injury at our partner's website. There are a lot of resources, obviously, also for survivors in Alaska. And so this is a long list of those resources that are available specifically in Alaska itself. And we will be joined in the conversation here soon by someone from one of those organizations. So with that, I'd like to thank you on behalf of Sonya and I for attending this webinar. We are very happy to have your questions here in just a moment. But there's also a link here to other webinars that you might be interested in that the Concussion Legacy Foundation is sponsoring as well.
Thank you so much, Dorothy and Sonya, for that great presentation. We do have some questions that we have already received, so we will get into those shortly. We were going to be joined by a member of the community who unfortunately was not able to make it today. So if you do have any questions about any Alaska specific resources or questions for the community there, please feel free to send those in the chat, and we will definitely follow up with you after the webinar to answer those questions. Alrighty, we are going to jump into a few questions here. First question, and Dr. Kozlowski, Dr. Crabtree-Nelson, feel free to answer whoever feels more comfortable with these. First question we have is, what assessment tools do you recommend for folks with low literacy who are not English speaking?
I guess my question is assessment of what? Because we could be talking about assessment of brain injury, assessment of just whether they are experiencing IPV, etc.
Absolutely. I think if you want to answer it on the brain injury side of things, and then Dr. Crabtree-Nelson, maybe you can add in any additional for intimate partner violence as well.
Sure. So, I mean, in terms of brain injury, to be perfectly frank, there's not like an exact set of questions that are answered, and in terms of like a checklist that someone would go through. Obviously, for a diagnosis of brain injury, that would be done by someone who is a physician, right? And physicians, hopefully, of course, are trained so that they can be able to accommodate and provide their assessment in such a way that encompasses individuals who might be having difficulty understanding them or bringing in interpreters, etc. So that's probably not the exact assessment tool I think the person who is asking the question is asking for. But in terms of brain injury and intimate partner violence, the Ohio Domestic Violence Network is really trying to provide a lot of materials in Spanish, and they are also working to try to get them translated into other languages right now as well.
Right. And one of the ones I think too that is linked on both our website and Ohio's website is the chats tool, which is helpful. And I know when they developed it and sort of vetted it across Ohio, it was targeted at more of a fourth grade reading, speaking level. So even if it's not in the language of the folks that you are working with now, it's something that either you could check out and download and adapt that if you would like for the languages needed, or ask the different questions verbally, but it was meant to be even asking those questions on a level that's, not medical, not academic, but more at a fourth grade level of understanding.
Wonderful. Thank you so much. And Dr. Kozlowski, this kind of goes back to a little bit about what you mentioned, but what type of providers should be included in a clinical care team for a patient with IPV related brain injuries, or someone that, maybe you have concerns of? What type of providers would you, want to ensure that they were connected with?
Yeah, I mean, if money is no object and insurance is not of concern, someone with a brain injury due to IPV really should have at least a primary care provider who can monitor and keep track of any other specialists that they might be working with. It's always best to potentially see a neurologist or a concussion clinic of some sort, because they will at least have the tools to assess which of all the different myriad and groups of symptoms someone might be experiencing, which ones are the most problematic. And because of what the most problematic are, they could then link that person to rehabilitative services. So, if someone's having problems with balance, they could do physical therapy. If someone's having trouble, keeping an organized life, they could work with an occupational therapist. So really the first point of contact would usually be a primary care provider, who would then connect them with either a concussion clinic or with a neurologist who works on concussion, with the caveat and understanding that they may not necessarily be fully trained and trauma informed to work with someone whose brain injury is coming from an intimate partner violence episode.
Thank you so much. All right, next question here. This one's lengthy, so I'm going to make sure I can read this correctly. I'm curious about where to find information or materials regarding helping survivors who are susceptible to intimate partner violence as a result of brain injuries, meaning they don't necessarily get a brain injury through abuse, but the behaviors and characteristics born out of a head injury make them more susceptible to abuse and or less likely to recognize being in or entering in to an abusive relationship before it's too late. So it sounds like maybe someone has experienced a brain injury previously, and the results of those injuries are making it more difficult for them to determine the relationships to be in, is how I'm interpreting that. But any insights into that?
I do think that it sounds to me like the sort of person being referenced or groups of folks being referenced do fall into sort of the broad category of disability community. And so there are different resources, especially if you can Google everything nowadays. But to be thinking in that mode, and even, as thinking even from of course, the wheel, once again, it's not a resource, but it helps, I think, someone who's working with folks who have various types of disabilities to be thinking about all the different ways that their past disability that they're struggling with now has impacted their relationships, has perhaps made it so that someone is taking advantage of them based on that. And then just there are resources for folks who are working with folks in the disability community. I don't know what is all, specific resource-wise in Alaska for that, but I know there are online ideas and tools for working with folks.
Absolutely. Thank you. And I'll just plug our CLF helpline here as well, just as another resource that if you or anyone you're working with is experiencing a brain injury, whether or not that is from intimate partner violence. The Concussion Legacy Foundation does have a helpline where we do our best to connect patients and caregivers to resources, providers available. We'll put the link in the chat that you can submit a helpline form to get more assistance there. Right. Next question I have here is, does the power and control wheel include female privilege?
I will admit I haven't probably looked at every single power and control wheel out there because there are so many. I can't say I've come across one that specifically labels female privilege, but there are numerous wheels out there that do talk about male victims, do talk about sort of, female identified folks being the perpetrator of abuse and how that can look, how that might be different. There are more and more resources out there as the understanding is growing, that there are, in fact, quite a few male victims, both from male perpetrators as well as female perpetrators. And that, of course, we know that many men do not come forward to discuss that abuse because they feel so much shame. Our society is not a welcoming society for that sentiment. And also females who have been victims of abuse by the hands of their female intimate partner is also challenging. Many, have stories of going to, their therapist, going to their doctor, and folks will be like, isn't that just a brawl? Or isn't, like, are you really getting hurt? Are you really scared of, and which is, and of course, you can imagine that person's not going to be very likely to then try to tell someone again. So yeah, no, it's great you bring that up. And there are some resources, although perhaps not exactly in the framing that you specified.
Thanks so much. All right, let's see. And we've got a few more minutes for a few other questions, so feel free to submit any last minute questions in the chat or in the Q&A. One other question we have is, could you speak to some of the biggest gaps in research related to intimate partner violence and brain injuries currently?
All. Sorry, I'm not trying to be flippant here, but really there's a lot of gaps. There is starting to get more and more data on this, but one is really just, we know 1 in 3 women, 1 in 4 men experience intimate partner violence, right? We don't know what the exact percentage of those really do have a diagnosis, of brain injury. So I will start with that very, very basic one. Just the epidemiology around it is lacking. There's more and more work being done on it. I see more articles being published on it all the time. Sonya and I put together a 2-issue volume on this intersection, but a lot more work needs to be done. Sonya, what do you think?
Yeah, no, what Dorothy said. And I think Dorothy and I connected probably back in 2016, 2017 surrounding this topic. And it is heartening to know that now by 2024, we know of so many more folks across the country who are interested in this research, both in, in both of our fields, right? In the field of social work as well as neuroscience. I know when we started there, you and Dr. Lifshitz would talk about the fact that, you'd go to neuroscience conferences and no one was talking about this intersection. And now more folks are. Also, I think, as Dorothy mentioned, we're still learning more about the repeat concussions as they relate to IPV, and as huge a thing as that blew up and changed everything in NFL and in sports, I do believe that's happening in our field now as well. Like we're sort of on the cusp of that changing how we provide both therapeutic and medical services for survivors. But we have so fewer numbers of folks who are having their brains, right? Having their brains, what would be studied once they die, who are survivors of IPV or known survivors. And so that takes time. But I do believe it's one of the things that has this such a pressing issue for me is that we talk about knowledge being power in the field of IPV. And I think survivors do need to know as well the ramifications for the multiple blows to the head, the multiple strangulations, that this not only is impacting them in the moment, but it can be extremely detrimental to their long-term, both physical health as well as their mental health.
Thank you so much. We did get one other question about the link to where the safety plan that you used was. That will be in the PowerPoint presentation that we will share in our follow-up emails. But any other information about safety planning or how to access the best safety plan when trying to help someone?
Literally Google is my friend. So like I said, this is my favorite one that I found, because you can walk through and use, it doesn't make you fill in things to get to the next screen. Some of them I find so overwhelming and overly comprehensive that even I, as the provider, am like, oh my God, I'm I'm overwhelmed already just thinking about all these steps. So I feel like this one was practical. But you can, if you Google short safety plan, long safety plan for emotional abuse, safety plan for physical abuse, once again, you'll find so many different tools that can fit sort of your specific practice of where you work.
Okay, thank you so much. All right, and then I think unless any other questions come in, this will be our final question. This one is from our team here at CLF, and would love each of you to answer. But what do you think is the most critical message for the public to understand about intimate partner related brain injuries?
I guess I'll start that it occurs. that brain injury is common. It happens following intimate partner violence. And if you know someone who is a survivor of intimate partner violence, to do what you can to support them in seeing if they can get help to identify whether they have a brain injury and get help for the symptoms they may be experiencing.
Yeah, I really echo what Dorothy said and what I had said right before the question about that. I feel it's so important for us to get this information out to survivors. And I will also say that from an incident that happened early on in my career as a clinician working with survivors, I err now more on the side of asking questions that might be uncomfortable because I want to ensure that I can at least give them ideas of how to be safe or have resources. So, if they disclose that there's been physical abuse, even in that first meeting with someone, I now would ask more follow-up questions. Have you, been hit in the head or been thrown against it? Like things that I was taught sometimes early on, like don't uncover all that in a first session. It's too much uncovering of trauma. But based on the fact that if I don't, that person can leave my office and may go to a situation that they didn't have all the information that I did on how to potentially, have somewhere else to go or be leery of what could happen next. So having that information and asking those tough questions, even in the first session, while of course underscoring that I believe them and am taking them seriously. And I'm so thankful that they shared this with me.
Thank you both so much for your excellent presentation today, and also for taking the time to answer some of these questions. We appreciate your time, and also all of the participants who are joining us today. Thank you so much for seeking out this education, for watching. As a reminder, today's webinar is approved for 1.25 credits for social workers, psychologists, nurse practitioners, and nurses. Participation certificates are also available, and instructions on how to claim their credits will be in the chat, as well as sent in the follow-up email. So thank you again for joining us, and we appreciate all of your time.
Thank you all very much.
Thank you. Thank you.